A very good evening to everybody. We welcome you to the second edition of WIGIL Journal Club. So I would like to invite our moderators, Dr. Vibha Varma, who's a consultant and head of the Department of HPB and Liver Transplant at Lilavati Hospitals and Research Center, and Dr. Aparna, who's associate professor in the Department of HPB Surgery and Liver Transplant at CMC Vellore. So over to you, Dr. Vibha and Dr. Aparna. Can introduce the speaker and we can go take it from there.
Good evening, everyone.
Thanks, Dr. Manpreet. The Journal Club for this evening is going to be presented by Dr. Kamakshi. She is our final year resident, and she's picked a journal from Journal of Liver Transplantation about the role of bridging therapy in patients listed for transplant for HCC. You can start your presentation, Kamakshi.
Good evening, everyone. This paper is on impact of bridge therapy for hepatocellular carcinoma in patients submitted to liver transplantation. It's a Brazilian multi-center study. The rationale for the study is that liver transplant is the ideal treatment for early stage HCC because it removes the diseased liver also, thereby removing the capacity of the liver to cause recurrence of HCC. So in places where only DDLT is done, the minimum waiting period from the patient when the patient is listed for transplant to the patient receiving transplant is minimum of 6 months. Because these patients get low MELD scores, they are given exception points so that they can reach the list soon. And most common criteria that is used for selecting patients for liver transplant in HCC is the Milan criteria, which is used as gold standard. But nowadays, centers also use expanded criteria. Because downstaging is a possibility with the help of bridging therapy, thereby these patients can also be assessed about their biology of the tumor, and thereby they can also be offered transplant, and they will also do with a better prognosis. So bridging therapy is used to downstage HCC, and the objective response to loco-regional therapy also is a marker of favorable tumor biology. And in spite of loco-regional therapy, if there is tumor progression, it means there is aggressive tumor behavior. Thereby, we get to know that the prognosis is not so good. So downstaging downstaging tumors which are under expanded criteria help us to know whether they're responding well to the loco-regional therapy. Thereby, we can select patients who have favorable tumor biology, thereby downstaging them, and then they will do well also after liver transplant. So this is the recent BCLC in 2025. It is almost same as the BCLC 2022. The only thing is that they have used the Q's approach, which is the complexity, uncertainty, subjectivity, and emotions, which are added into the BCLC 2022. But I would like to just say that TACE is used in early stage HCC where the tumor size is large, and also in intermediate stage HCC where it is multinodular but there is preserved liver function. So just a brief introduction about TACE, because in this study, the most common bridging therapy used was TACE. Transarterial chemoembolization, the principal is selective tumor ischemia, where only the artery supplying the tumor is embolized, and there is selective tumor ischemia to that region, and then the tumor necrosis. So the most common chemotherapeutic agent used is doxorubicin, and it is also said that when the embolizing agent is injected into the artery, it also goes into the portal vein through the arterioportal communication, thereby causing double embolization of the tumor. The most common indications for TACE in HCC is early stage of HCC with large tumor size, intermediate stage, and as nowadays it's also used as bridging therapy. In TACE, the dropout rate is 3 to 9.3%. Like this is a wide range seen in various studies. Coming to the paper per se, so the aim of the study was to evaluate the impact of bridging therapy on overall survival, oncological outcomes, and oncological outcomes such as the tumor recurrence rate and the recurrence-free survival in HCC patients who are submitted to liver transplant. And they had obtained ethical clearance before the study. The study design was a multi-center retrospective cohort study. 13 transplant centers in Brazil were included in the study, and the total number of patients were 1,406. After applying their exclusion criteria, the total number of patients were 1,119. And it was a 10-year study from July 2006 to July 2015. Inclusion criteria was they had a criteria called Brazilian Milan criteria, where the tumor nodule size was 2 to 5 centimeter, or up to 3 nodules between 2 to 3 centimeters, or any number of nodules less than 2 centimeters. The exclusion criteria included incidental HCC on explant pathology, or insufficient data because it's a retrospective study, or unconfirmed diagnosis of HCC, or hepatocellular along with HCC, along mixed HCC, and patients who underwent LDLT, or if the follow-up period was less than 12 months. They had used the modified RECIST criteria for assessing the response to the bridging therapy. So according to the MRECIST criteria, the complete response was defined as disappearance of any intratumoral arterial enhancement in all the target lesions. Partial response was at least 30% decrease in the sum of the diameter of all the viable lesions. Stable disease was anything that does not qualify partial response or a progressive disease, and progressive disease was at least 20% increase in the sum of the diameter of the viable target lesions. Coming to the results of this study, so the most common indication in this study was HCV, hepatitis C related cirrhosis, thereby hepatocellular carcinoma, and bridging therapy was given in 735 patients, and only 78, that is 8% of the patients were able to be downstaged before undergoing liver transplant. Other methods of bridging therapy used were PEI, RFA, surgery, or combined modes of bridging therapy. But then the analysis doesn't include all these because the numbers were very less. So the analysis they had done only for the transarterial chemoembolization done as a bridging therapy. And patients who had complete response according to the MRECIST criteria were 37%. Partial response was seen in 38%. Stable disease was seen in 12%, and progressive disease was seen in 13%. And they had also looked into the explant pathology of how differentiated the tumors were. So complete tumor necrosis or after bridging therapy was seen in 69 patients, which is 7% of their study population. And well differentiated tumors were 10%, and moderately differentiated was the most common, which is 71%. So this is the Kaplan-Meier curve, which shows the overall survival in patients who underwent bridging therapy and who did not have bridging therapy. So it is seen that the overall survival with or without bridging therapy is almost the same. And this is the Kaplan-Meier curve, which shows the recurrence-free survival in patients who underwent bridging therapy or without bridging therapy. This also was found that there was no change in recurrence-free survival among patients with or without bridging therapy. They also looked into the impact of response to bridging therapy according to the MRECIST criteria in post-LT HCC recurrence. And they found that the overall survival again was almost same in patients who had complete response or partial response or progressive disease or stable disease. But the only significant finding in this study was that the recurrence-free survival was better in patients who had complete response to bridging therapy, which we are seeing in the second Kaplan-Meier curve in this picture. They also did a multiple Cox regression for seeing how much higher risk patients with complete response or partial response had in comparison to patients who had complete response. So they found that the analysis of patients who received bridge therapy and had a wait list of more than 6 months showed no difference and than who received or did not receive bridging therapy. And patients who had complete response had higher recurrence-free survival. And patients with stable disease or progressive disease had 2.92 times higher risk of recurrence compared to those who had partial or complete response. Coming to the discussion, so the waiting period, if it is more than 6 months, usually patients are offered bridging therapy. As such, there are no guidelines currently to guide us which therapy has to be preferred over which. And it is generally center-based decision whether to give TACE or TACE plus RFA. But most commonly used is TACE or TACE in combination with RFA. And the radical response to local regional treatment before the LT could be used as a clinical marker whether the tumor is responding and how the tumor biology is. And in this study, they found that the post-transplant recurrence rate after bridging therapy was 8%. So the strengths of this study were that it is a multi-center study, and so the sample size was large, almost more than 1,000. And uniformly, all the centers had used doxorubicin as the chemotherapeutic agent in the TACE that they had done as a bridging therapy. And the study period was quite long, which is 10 years. And their follow-up was, the mean follow-up was 28 months, and the maximum follow-up they had was 60 months. The limitations were that it is a retrospective study, and because it was a multi-center study, there was so much of heterogeneity into whether there were standardized guidelines as to which patients had to be subjected to bridging therapy. And the sample size, actually, when we see the result tabular column, we could see that the number of patients included in each category was different, and there was no explanation given to how many patients were included in each category and why was that discrepancy. And they had not also looked into the factors associated with successful downstaging and dropout. Like they had not looked into the AFP levels or the number of bridging therapy sessions given, and how many were CTPA, CTPB, and CTPC. And they had also not looked into the mean time interval between the bridging therapy and the liver transplant. And in the survival analysis, they had included all cause of deaths, like they had not looked into specifically HCC related death. And the bridging therapy per se was basically used to see how much is how easily like the tumor biology can be assessed and how does it help in reducing the waiting time for liver transplant. But they had not looked into the dropout rates. I would like to compare this study with the MERITS LT consortium, which was done, which is a study done in 2021 in USA, and this was a prospective study, and they had selection criteria, like they had this criteria that single lesion 5 to 8 centimeter or 2 to 3 lesions less than 5 centimeter with a maximal tumor diameter less than 8 centimeter, or 4 to 5 lesions less than or equal to 3 centimeter with maximal tumor diameter less than 8 centimeter. So they had fixed criteria of who they will subject to bridging therapy. And they also had criteria for successful downstaging, that the residual tumor diameter and the diameter should be within Milan criteria, and the criteria for downstaging failure and exclusion. So if the patients do not fall into the criteria for successful downstaging, they were excluded from undergoing liver transplant. And they also looked into the timing of the LT in relation to the downstaging. So they had also compared TACE and TARE because this was also a multi-center study. Many centers had also used transarterial radioembolization as their method of bridging therapy. So they had also compared TACE and TARE, and their values, their result was almost same for TACE and TARE. So the total number of patients included in this study was 209, and the patient number of patients who were downstage to Milan's criteria among the 209 were 174, which is 83.3%, and who did not downstage at all were 35 patients, which is 16.7%. And among the patients who were downstage to Milan criteria, 63 had undergone liver transplant, and there was a dropout of 15 patients. And there was tumor progression in 16 patients and liver-related death in 9 patients. Among the patients who had liver transplant, the recurrence was 7.9%, which is almost equal to which was seen in other studies. And in this study, because it was a prospective study, the mean follow-up period was only 1.7 years, and their survival post liver transplant at 1 to 3 years was 100%, 95 and 83% respectively. And they also found that from the first downstaging procedure to the LT, the survival was 92.5% and 73% at 1 and 3 years. And there was no significant difference between TACE and TARE when used as a bridging therapy. This current study, the Brazilian study, which I had discussed, in that they had shown overall survival of 79% at 1 year, which is less compared to that seen in this prospective study. Thank you.
Vibha ma'am, would you like to start with your comments on the paper?
So Kamakshi, a nice presentation. And I think the topic is very relevant. Just wanted to add that loco-regional therapy has come in both LDLT and DDLT centers. And this is basically talking about DDLT setting, where it is more of a bridging therapy than a downstaging therapy. But of course, that's one of the things which has been followed in all the centers, because it's not only the size which matters, it is also the tumor biology. So bridging therapy is just to see that they remain within the criteria for transplant, whereas downstaging is where you want to include more patients. And I think you discussed well, but and the limitations of the thing was brought out. I thought that the time between loco-regional therapy and transplant is important. In most of the studies, they have found that it should be between 4 to 6 months. And what is the difference between a LDLT setting and a DDLT setting? Maybe a slide you could have discussed with more papers which have come out for LRT in LDLT settings. And the number of sessions also matters. In fact, in one of these studies, they have found that if your loco-regional therapy sessions are more than 3, it indirectly shows that the tumor has a poor biology. So I would keep it open for others to discuss.
Sadaf, yes,
Yeah.
ma'am.
Yeah. Hi, Aparna. Very nice presentation. A very good paper picked up. But for Kamashi, I would like to put up a point across, as Vibha has rightly put it, that these are two concepts. Downstaging, maybe the concept came from the trial, what she discussed, merit trial. They had tried to take almost all comers also in one of the studies. And then subsequently, they took it with strict some guidelines where you want to convert a stage beyond acceptable for liver transplant, and then you go ahead with transplant therapy, and they have shown very good results. And the concept of bridge therapy is more for where you have scarcity of the availability of donors, like if you are a center which is dominantly going for disease donor transplant. Having said that, I have the paper is very nicely made. The study is very good in concept to response those who had early transplant versus those who were bridged with some kind of treatment, and most of the time it was stays. But if you look at it more critically, where she has put a brief side results of those who had complete response. And they've also said that the recurrence free survival in the major part of the study, they had put it that the recurrence free survival was better in patients with complete response. But if this subset of patients who had complete response, say if they did not have liver transplant, what would have been their follow-up? With few settings of another loco-regional therapy, whether they would have a similar kind of overall survival or recurrence-free survival. And and another food for thought is that, say, suppose if almost 50% of the patients required good amount of time to wait for liver transplant, whether they could be subdivided into two subset of patients, those who received bridging therapy and those who did not receive bridging therapy, and what were their results subsequently after going for a liver transplant. So we would have been more clearer, but as of now, the paper was very good, and I congratulate the team of CMC Vellore. Now there are many centers who are coming into liver transplant, and it's a very, very important topic to be discussed. Uh, Thank you. I would like to take comments from Vibha for the 2 points which I said, and from Aparna. You CMC are doing liver transplants, huh?
Yes, ma'am. Ours is predominantly a DDLT program, which is why we actually wanted to pick this paper up. Continuing on what you had mentioned, ma'am, that was one of the main things I thought was slightly flawed in this paper, because though the aim of the paper talks about the role of TACE as bridging therapy, in their analysis, they've actually included 78 patients whom they say have been downstaged, and they talk about 8% being the downstage. Did they have to be included at all? Was the question, because if your intention was to only analyze the role as bridging therapy, then that group of patients, either as a separate subgroup analysis, or whether they should have been excluded, is something I was not sure, because here the intervention of TACE is done for all these people, because they are to 50% of the patients, the wait list time is more than 6 months, according to this study. So everybody starts off with a TACE. There is no selection of who goes through TACE, and about 80% of patients are within Milan criteria, and even after explant, about 70% are still within Milan criteria. Still, all of them did have as bridging therapy, but the 78 patients that they talked about downstaging, why it had to be included was something, it looked little confusing even in the paper, though the aim was only as bridging, why they had to talk about downstaging. My other question was based on what we eventually learned from the paper, being that it's only possible to achieve recurrence-free survival when we have complete response. How do we actually take this information then? We obviously are not going to be able to deny transplant to somebody when we are not able to see response after TACE. So it is only going to be in terms of looking for other predictors of good biology, this also being used as another predictor of biology to guide post-transplant surveillance, or how will this information actually be useful in selecting our patients if we so happen to do bridging therapy for all our patients, suppose like this?
So
Exactly.
I have a comment on that. That I recently published a paper from Max in JCH, where we compared upfront transplant compared to LRT and transplant. It is a retrospective study, and the study is over a period of 16 years. So it's a long drawn period, retrospective. Still, we did a propensity score matching, and we found that there are predictors of complete pathological response. And there are very obvious factors, if I say that. Apart from the age, which is not very obvious, the size of the tumor, the pre-transplant AFP, the differentiation of the tumor, and presence of perineural invasion. So these factors, if you see, these predictors of complete pathological response have been studied. And those who had complete pathological response have a better overall and recurrence-free survival is not new. So, and we cannot upfront predict that. You can predict the size, but you can't predict that some of the tumors, they don't have high AFP. So there are other predictors like avidity of hepatocellular. There are inflammatory markers which can predict. So you can only predict, but as far as denying transplant, if they are well within the criteria, is not possible. You can only prognosticate. You can be closely following them so that whenever there is a recurrence, you start treating them. So you can only have predictors of recurrence. You can have predictors of response. It is there in our paper. And we also are from LDLT. We excluded all the DDLT. So there were upfront transplants. There were patients who had high AFP where we offered LRT. Now, the other limitation is that if the patients come with child's B and C or they have decompensation, you cannot obviously offer them LRT. But are you going to decline transplant if they have a tumor within the criteria? So all these are factors which we cannot answer, but I think it's a good thing to upfront think about loco-regional therapy when the patients are beyond Milan or if they have a poor tumor biology.
Exactly. And if they don't have the living donor program available or donors available. So that's an important point across. Very well taken.
Just a suggestion for people who are presenting in the journal club. I don't know whether it's relevant, but when I was a student, there were 4 questions which we used to answer after the journal club. And it was something which Dr. Nandi would not leave us if we don't answer those questions. So what is new in the paper when you critically analyze? Is it new? Is it true? Is it important? Shall we change? So I feel that if you try and answer these questions, you cover most of the literature. You do a lot of lateral studies. And in fact, more than your actual paper presentation, your last bit of slides, they teach you more because you tend to study the papers which have been published on the topic and it prepares you well for that particular topic. So loco-regional therapy as a bridging therapy, and now it is one of the treatment modalities before transplant. There's a long change. So initially the criteria for transplantation was just expanding as far as morphology and number size was concerned. But now it is more tumor biology. So you have more and more other factors like AFP, PIVKA, avidity to FDG, the inflammatory markers. All these are being taken into consideration. It is because we not only want to include more patients for transplant, but we want them to live longer, recurrence free. So that is the change in the concept. That is why the PCLC scoring also or the staging has changed a lot, where patients beyond A and part of early B were not offered transplant. But with loco-regional therapy coming in, beyond B and C, we are transplanting. So I think this is something as students, people need to read up. And it's very interesting because a lot of things are being worked up still on biology of the tumor. So a journal club presentation should finish your topic for the exam. Okay.
So, ma'am, I have a question that we keep discussing TACE versus TARE, but how many centers are actually using radiation TARE therapy in India? Is it actually practical in every place? Because what I have seen is that TACE is much more commonly used because it's easily available compared to.
Yeah, exactly.
It is
At least
available, but it is costly. You know, you have to understand that TARE, it's actually become now cheaper because initially if one patient is supposed to have TARE, they will calculate the dose and get that radiation beats. Now you have more patients, the centers which are performing more transplants or seeing more number of cases, they combine the few cases and get the radiation beats. So the cost incurred by each patient is probably less. But if you compare TACE and TARE, the overall survival and recurrence-free survival is almost the same, but the cost difference is too much. So in fact, I would ask people in the audience, they should share their experience because this is what we experienced in Max. That patients who are not affording, you spend about 10 lakhs plus for TARE, whereas it is about 2 to 3 lakhs or less than 2 lakhs for TACE per session.
And Manpreet, there are specific indications for TARE, right? So to do TARE for every patient is probably an overkill. But that said, when you have the right indication, it's a very good modality. The limitation is, of course, the cost. And something which is to be mentioned in a forum like this, where there are so many younger people watching this, is that I think the sorry, the Tata or the Indian, the Mumbai Nuclear Medicine Center. Sorry, I don't remember the name. So
It is
they
a
have come.
Homi Baba Center.
Yeah. Sorry,
There we
yeah.
get.
So they've come with their own, with our own Indian version of tear beads, which is going to be a game changer, hopefully in the future, and we should look forward to it.
So Manpreet, around tear, even in most centers, would still cost around 16 lakh rupees versus like what Dr. Vibha was saying that TACE is about 2 to 3 lakhs. So, and then apart from the cost itself, tear is something that you can do only once in a patient. Beyond that, you cannot do. And you need to also look at the lung shunt fractions. Where it really scores over your TACE is if you got a portal vein thrombus. Now, TACE can't deal with that, but because here there is an element of radiation that comes up, and I think there's a paper from Medanta where they showed in a not a very large series, but they showed that they used tear and they converted a tumor thrombus into a blank thrombus with tear and then went ahead and did the transplant. So those are situations where tear has its place, but in patients who do not have this, probably TACE is a cheaper option, a more repeatable option compared to tear.
Right.
And now with immunotherapy being used more frequently, I think again, the kind of cases that we used to send for tear are kind of getting divided with, some of them are being offered immunotherapy. And, the outcomes of immunotherapy is also very good. So it's going to be a lot of options in the future. It's going to be personalized medicine. So, and we'll need more, discussions, more research, more journal clubs on this in the future.
Air also has less post-embolization syndrome. So that is one of the positives of TARE. Apart from the penetration and all, people are doing radiation lobectomy. And I have not personally had any such experience, but you've got papers where they are actually doing giving extra dose because it is more focused, localized, and gives rise to more less post-embolization syndrome. But yeah, that is for the future, and we'll have to have more studies.
साबुदाना बना रहा है खाली रोज साबुदाना खाता है हाँ कम रहता है ना कैलोरी
I would please request mute. Yeah, please go.
There's actually a paper in transplantation this month, which has actually come from US, which is the other paper I'd sent you, Dr. Manpreet. That is the one which is actually showing trends of tear actually increasing quite rapidly in the US. But background of it, again, the cost does not seem to be different there either. Those who were not covered by insurance and the Hispanics and people who couldn't afford are the ones who still ended up with TACE. But overall, their numbers for tear seem to be increasing, and the graph seems to have completely crisscrossed with TACE coming down and tear going up. They had a very short-term follow-up, so not much to comment on the advantages as it is, but it was more of a paper commenting on how the trend has changed towards tear for bridging therapy in the US. So,
Yeah. Yeah, but my question is more about availability. Like in my center, at least, I know that my interventionist can do a taste because chemotherapy drugs are easily available. But I don't think we can do a tear because those are not available. So how many centers actually do have it for us to be?
You guys have a radiation oncology unit as well.
Yeah,
So it will be them who will have to procure the agent through their license.
right.
And then so it's going to be a combined thing between the radiation oncology and the
Yeah.
Most of the cancer centers nowadays, they have a radiation unit, and doing a tear is not a problem, I think. But yes, some of the centers, they are still developing, having a license and then procuring the leads. And if we have a Indianized thing, I think it will increase in number.
Yeah, I think that Tata
Because that is one
called
of
Baba
the
spheres.
limiting factors.
It's called Baba spheres, if I'm right.
nice. So any other questions that anybody has or any comment that anybody wants to make?
It would be good to have a guideline. So what we did, when I wrote the paper, in the end of it, are we having a clear guideline as to who should be the person who should be offered loco-regional therapy versus upfront liver transplant, especially in a LDLT setting? When you are on a DDLT list, don't have a donor, bridging therapy is an option. There again, you have to see which criteria. If you are well within Milan and you wait beyond 6 months, okay, that's the criteria which outside India people are following. But within our country, who are the patients A, B, C that you offer loco-regional therapy? So I would say anything beyond Milan. And anything with AFP above 1,000. This is what we wrote, but people take 400 also. So multiple tumors, or they have intrahepatic, some of the vessels which are having invasion, and more number of lesion, high AFP beyond Milan. They don't have a living donor. I think these are the patients where you should be thinking about loco-regional therapy. Even with living donor, if you have beyond 1,000 AFP, I would offer them, because we are now worried more about long-term survival and rather than only doing a transplant and leaving them alone. Even immunotherapy, people are giving downstaging and then doing transplant. So I think these are some of the things for future studies. We should have our own guidelines as to which are those patients where we should offer our loco-regional therapy before transplant, because this is gray. This is not black and white in our context.
Yes, ma'am. So if there are any other comments or questions, please raise your hands or speak. Otherwise, I think Dr. Kamakshi can answer the 4 questions that Dr. Vibha said. Is it new? So I think TACE versus TARE has been there for quite some time. But as bridging therapy, probably a new concept. Is it true? I think we've discussed that it seems to be true. And ma'am, what are
I
the...
think they didn't cover a lot of things, like we would have liked what was the interval, what were the number of sessions offered. And as Aparna was mentioning, why did they offer as a downstaging when the topic is actually bridging? So they were not true to their initial aim.
Right.
But it's an important study, I would say. It's an important...
Manpreet and Vibha ma'am, let her answer these questions. Kamakshi should answer.
Yes, ma'am. Actually, like TACE is not new, but as a bridging therapy is new. Like in our center also, like as ma'am Vibha ma'am said, like we don't have proper guidelines on which patients should be offer bridging therapy, or during the waitlist period who has to be given this bridging therapy. So we thought this would help us learn about it. And coming to downstaging, so we usually take patients within Milan criteria. So I mean, in our center there's no question of downstaging, but then in this paper like only 8% of the patients were downstage, and they had not much analyzed into what were the factors that contributed to the downstaging. Like they had not discussed about the AFP levels or the quality of liver. Like there were no like number of the loco-regional therapy sessions that the patients had, or the time interval between the loco-regional therapy and the time of liver transplant. They had not looked into the factors which helped downstaging, if at all they wanted to discuss about it. And yeah, I mean, because it was a retrospective study, I think that there was so much discrepancy in the data also.
Ma'am's last question was, how can we change?
As ma'am said, we should have a guideline on which patients need bridging therapy and like basically as the aim of the study was bridging therapy to liver transplant. So we should look into like which patients will actually benefit from the bridging therapy before we offer a liver transplant. So I'm not sure how to regularize that, but then we should have guidelines on it so that we can select patients more carefully.
So as a bridging, if they are waiting for more than 6 months, is what is being followed, even when they are within Milan. And you've listed, because for listing, you need to have a criteria, and they are all within Milan. So to bring them within Milan, you have to do a local regional therapy or a downstaging therapy. But while on the list, it is okay to do a bridging therapy. For that, you don't need a guideline. It is there. If your patient is waiting for more than 6 months, doesn't have a living donor, and has a tumor within Milan also, you need to offer them TACE or something.
Yes,
So
that is what we follow in our center.
Progression of disease. Yeah. They don't have progression and they don't have a dropout. So I would say that is clear, but what is not clear is move to downstage. And is it only morphology or it is the AFP value or the biology? That also we have many studies, but to form a guideline would be something which we are looking forward.
So I think it's a good topic that was selected, but being a retrospective study, there were certain aspects which the study could have worked on, like you said, to have a more standardized set of cohort of patients uh, that is being studied. And definitely, especially in the Indian scenario, I feel we get a lot of patients who are outside the Milan criteria. So how to deal with that also. So if there are no more questions or comments, I think we can wrap up this session.
Thank you. It was a nice session.
Yeah. Thank you. And thank you to all the residents who have joined in. We have a YouTube channel called WIGIL India. And we also have a Instagram, Facebook, and Twitter handle where we announce the next session that is coming up. And yeah, so anybody who's interested can follow. All the talks that we have are put up on YouTube around 2 weeks after they have been done. So anybody who has missed it can also follow it on YouTube. So thank you everybody for coming. Thank you, Dr. Vibha. Thank you, Dr. Aparna. Thank you, Dr. Kamakshi. And thanks a lot to Sadaf ma'am, Dr. Ragini, Dr. Shruti for participating actively. Thank you, everybody. Good night.
Thank you very much.
Thank you.